Hello, viewers. Welcome to the Para Podcast. This is a show that discusses EMS in Africa, and we try and take it to the world. Today, we have an emergency physician, Dr. Maggie Magano from Namibia. I can't help it, but I'm very proud to say from Namibia. You know, that is not something that you say every day. So, Dr. Maggie, thank you for being here. Thank you for joining us today. How are you doing?
I'm good. Glad to be here. Really, really, what an honor to be amongst such great. You are literally my tribe, as we just said. You're my tribe, and it's really good to be here. And I'm excited for this session.
Uh, when I was speaking to Paulus, he said, you know what, I know you guys are doing the para podcast, but I think if you want to pick one of the brightest minds in Namibia, I think you should speak to Dr. Maggie. And I was like, who's that? It's like, you know what, let me introduce you. So this is how I got to know you. But for the viewers that might not know, who's Dr. Akuaake?
I'm just humble little me, an emergency physician, currently working in Namibia, in the coastal town of Walvis Bay. Um, my medical career is still in its infancy, if you want to say so. I started off with pre-med. That was my first encounter with with medicine at the University of Namibia. Then went on to do medicine at the University of Stellenbosch here in South Africa in Cape Town. That was 6 years, and then went back home to do my internship for another 2 years. At that point, I had an inkling that emergency medicine was what I wanted to get into. So I pursued getting into the program, which was the then combined EMCT, which was the University of Cape Town and the University of Stellenbosch, their emergency medicine program. So I did my Masters of Medicine as well as my fellowship in emergency medicine as well, with the combined program, and graduated a year plus minus a year ago, and I've been an emergency medicine specialist since.
Wow. Um, I was just gonna say, usually when you leave high school, there's usually few options. I'm not gonna mention what Malusi wanted to be. I think Thulani and England was the wanted to be, but but you're usually caught in this predicament where there are, different career options around the table. And I remember we were planning mine with Paulus. I'm saying his name so often now, but and he had sociology. He had I think the massage wanted Malusi wanted to do
Somatology.
somatology. Imagine Malusi doing somatology right now.
I'm going to massage you.
so, so what did you want to be? What options did you have? Was being a doctor sort of like your priority, or did you have anything else?
So, look, I mentioned this that really I am an introvert, and I spent most of my childhood literally just in my room. And I thought I would continue in that trajectory, maybe become an architect, do geology, like go underground. And I got accepted for those career choices. And medicine was just a by and by. And without going into the specifics, my parents nudged me to the right direction. I mean,
Sounds like a lot of influence.
so my parents nudged me in the direction of medicine since they are both in the medical field as well. So it's not like I don't regret it. I am grateful, and I don't think I would be the person that I am today if it wasn't for the whole journey of medicine. So I'm grateful for it. But again, sometimes you do wonder about the other choices, being underground, and yeah. But it's still, I'm very happy to be where I am currently.
I know, I think our previous guest, or at least the last podcast that we released, or before the last one actually, because we just released Mrs. Mfeka's one. She wanted to be a DJ, but somehow ended up being
No, it's Busi. That's Busi.
Pussy. Yeah, she wanted to be a DJ.
Yeah.
So I think they are always like very interesting career choices. Now to move from there on, I remember when you're chatting to Dr. Wachira, he said that he was a doctor at the time, and he was working in the wards, and he just sort of felt people were just dying around him, and he just really did not know how to apply emergency medicine. So
Yeah.
when you graduated,
Yeah.
what prompted you to get into that direction of being an EM? Did you also see people dying around you? Did you just feel like people around you did not really know what they were doing? Or was this also family sort of like motivated to say, I think we need to cover this space in the family?
Looking at even in mid school, there is this one time that I remember, and it's during internal medicine, so there's no judgment at all. I was third year, and we had just done BLS training the previous day in the skills lab. So we knew how to do chest compressions, we knew how to put on ambu bag and start bagging. And we were on ward rounds the following day with the resident, and we just passed by this lady who looked like she didn't look well. She was like at the end of her life. And maybe the reason why I didn't do internal medicine, because it just felt like everyone was dying. But just after we had passed her, the plan was just to continue as is and hope she becomes better. And just as we had passed her, the nurse now calls us back to say that she's not breathing. And the way that resus was conducted was not the most traditional form, where it ended up where I had to take the lead and be like, okay, actually, I just did BLS. Are we not supposed to start with chest compressions and get the resus trolley? So, and I saw that the resident was very flustered at that point. So for me, that was a turning point for me that, look, this is really what I wanted to do. But it was also just the competence of knowing what to do that helped. But even in internships, I had to come to South Africa so many times to come and get my advanced life support courses. So my ACLS, my ATLS, my pediatric advanced life support, because those courses are very scarce in Namibia. They are a little bit more now, especially now that we have Sikuvi and Sitembi who are doing them in the country. But back then, I had to use up all of my vacation leaves just to come and get them. But I fully believe in the courses, but I maybe just don't agree sometimes with how the courses are structured, in that now I come to South Africa, I see how we should be doing ACLS or ATLS with all of these resources, but I go back and you know that most of these courses are structured around teamwork. And you go back and you're the only one in the team who knows what to do. You're the only one in the team who knows what the resus trolley should look like. And then you're standing there and you're like, guys, let's get the defibrillator, get the pads on. Everyone is like, which pads? Okay, let's get the pedals on. Okay, does someone have a Denos? And these are real life things. That says, oh, a Deno, what? It says, okay, can someone get the saxamethonium? Okay, those are more common drugs, but it's just a thing of, ideally, it would be nice if these courses were actually run in the department where you are going to be doing these resuscitations. And even in my current practice now, whenever I do simulations or drills, I do them in the setting where it's actually going to happen with the team that it's going to happen with. So I go to theater, and in theater with the theater team, they come and we do the resuscitation. We go into the pediatric ward so that they get comfortable with their resus trolley. They get comfortable with their equipment because they're the ones who are going to be using it. So even if we do it in a building elsewhere, you still need to come and apply it in your own setting. So yeah.
I
Yeah,
think,
I
yeah,
think it's the same issue that we have as paramedics, because
Mm.
your ACLS and ITLSs, they're all designed around the hospital. It's like you're in ED and you have to work with the team. There's a scribe and everything. And then you go to a place, let's say in South Africa, you have 3 people that work in the ambulance and you are the ALS, and then you have to work as a team. There's no scribe there. You'd write afterwards, and you take a lead because you are the ALS you're expected, and then you have the crews doing compressions, and you are responsible for the drugs and the airway. It's totally different. Yet it does help to know the dosages, the times that they teach. But I do think that there should be some reconfiguring that happens. I think Caleb from Coffees and Cases does assist in those spaces where they bring in the training that is relevant to your department, which is pretty cool. I think we do need to try and adjust them to fit our setting.
Yeah.
Sorry, can I add too? It's different in Australia. If there is a resource priority one, automatically there will be 2 ambulances that are dispatched to that, which means we've got minimum of 4 people and then possibly a team leader, 5 people. So you all work together. And there is a strategy that have been created where you bring, the first crew bring all the equipment, the second crew will bring the backup equipment, your oxygen and stuff like that. And then whoever takes the lead, there is a card where you can be a scribe, you can write once everything is in synchrony. And it's everyone's responsibility to do compressions. Fatigue is managed. So there is a bit of structure there that have been tailored based on the service. I think it can be done too, even in the emergency department. I think what I've seen also here is that there will be a team that is dedicated each day for a resus. So everyone know, part of the resus team, you know your responsibility. They check their ventilators. They know this is the team lead and stuff like that. Yeah, let me stop there.
Look, while we're still on this aspects, well, coming from South Africa, I know if you're going to a resus, it's only the 3 of you. There's the critical care paramedic or the emergency care practitioner or the ALS, and then 1 ambulance. I wish we had that system whereby we have, they send additional support for assistance. But in any case, I wanted to ask you, Doc, can I say Dogotela? We are doxing you because you understand the term now. You've been in South Africa. Dogotela. Okay, let me stop being playful. What I want to ask you is, it sounds like there was a culture shift, with your experience when you went back to Namibia. And how did that culture change or culture shift that you introduced, whereby you do in-house training within your team, did that improve the things that the team and patient care?
It's because I am now in a private hospital. The culture shock in terms of resources was actually for the better because we have the resources, and when I got to the hospital, I really appreciate the fact that they had already had the initiative of having CPR teams. So every single morning, one of the nurses has a sticker that's either written recorder or circulation or breathing, and there is a structure for ringing a bell. So every single ward has a bell or a CPR bell, and the team come and start CPR. And getting back, it's just a matter of doing it in the individual areas of care, whether it's in theatre, whether it is in the wards. It's the comfort. And if you are comfortable and with any resuscitation, it's the chaos that usually ensues and decreases the outcome of the patient, because no one is doing effective chest compressions. No one remembers to put the oxygen on. No one starts and puts on the defib pads because everyone is running around. So for most of the nurses, they feel that doing the simulation consistently, and we do it every single month. They do it every single week, but I am present every single month. I come and make sure that we do pediatric, we do adult, we do anaphylaxis, the different emergencies, just for people to simulate it and become comfortable in that setting and reduce the chaos. And in as much as I'm not measuring patient outcomes because we don't get that many resuscitations, we try to prevent it more than we actually get into it. what the nurses and the feedback that is coming back is that they're grateful for the opportunity to be able to practice these skills, especially with a doctor in the background guiding them, and they are becoming more comfortable. And in the event that when they do have resuscitations, it's a bit more seamless because they know they must bring the resus trolley, they know that they must do effective chest compressions. And every time I do it, every single month, there is always improvement. You see, oh my goodness, wow, there's actually someone who has started recording. You guys getting the pads on quickly, them being comfortable with shocking. And that was the thing. It says, and you'd wait for the doctor, but they shock and they're like, we're comfortable with the defibrillator. And, we need to, it sometimes takes time for the doctor to get there. So that initial and getting ROSC. And for most of the resuscitations that I get or they call me to, by the time you get there, it's usually you get ROSC within the second or the third cycle. So I'm really proud of how much the teams are growing just in that particular aspect.
Well done.
Yeah, no, it sounds like it. I'm impressed with the tag. When it's like, you're the CPR person, or like that is so cool. Like, I'm not
Yeah.
sure if you can do it in the ambulance as well to say that, hey, you're gonna be the CPR person if you get a cardiac arrest. Probably might not be applicable, but yeah. I was just gonna add that, when Malusi said how they do it in Australia and Thulani, in South Africa, like my experience in New Zealand and London is just in London, usually if you have a cardiac arrest, you'd at least be 5 on scene and you're most likely going to get backup. And usually within 5 minutes or so, you will have backup because they will send everyone and everything to that specific call. In New Zealand, it's usually you have the firefighters. The firefighters will respond to every cardiac arrest. You don't do any chest compressions. Yours is just to facilitate the care. You don't carry any bags. You don't do any extrication. They do all that. All you have to do is just focus on the care. And usually you're going to get a second ambulance. So it's going to be 4 of you. So if you do have the resources to coordinate a cardiac arrest, which I think is really, really great. Now, just leading into my next question, I'm not really familiar with the EM space in Namibia. Do you guys have a society, and how do you guys integrate with the pre-hospital setting? Because I do know that it's quite a close connection. Not one that operates in isolation, and I think you work closely together. So, what's that collaboration like, and how many EMs are there, and how do you meet with the paramedics every now and then, just to try and establish that foundation so that everyone can know who's who? If you can just chat us through that part.
Yeah, so I'm still very new to the Namibian EM space, but we are 5 emergency physicians currently in the country. 2 are in private and 2 are in state. And they are the ones who are really just pioneering the emergency care and sensitizing the whole country and just the medical fraternity to emergency medicine. And we don't have an association. We are busy registering one currently that hopefully will help us also drive most of the policy that we're trying to develop to ensure that we standardize the care that is given in an emergency, and usually just like starting off with recognizing that this is an emergency and all of us to be able to speak the same language, whether it's in the pre-hospital setting, whether it's in the emergency department, whether it's in critical care, all of us should be able to speak the same language when we speak about emergency medicine. But our relations with the pre-hospital, I think, again, it's one of those things where in the departments where we have an emergency physician, and all of the emergency physicians that are currently in Namibia have all practiced or have all done their programs here in South Africa. And one of the rotations that we do is called EMS. So we get a response car and we respond to whether it's a mass casualty or if the paramedics are struggling a little bit, they're allowed to call us to assist. And sometimes we even go on primaries with them. And in that, we really get exposure to the pre-hospital setting. We get sensitized to what you guys do and what you guys go through. And that has really changed most of our perspectives when we talk to the pre-hospital teams and being able to foster that collaboration. For example, with where I practice currently, that relationship, we started building it from the word go. Within the first week of me starting at the hospital, we had a mass casualty, and in our little emergency center, we had 30 patients arrive at the hospital, and we needed to coordinate that and the debriefing sessions. I was very adamant that we needed a debrief sessions with the pre-hospital guys, and we started to build that relationship from the word go. And if anything changes in the emergency setting, I never do it in isolation. I always make sure that the pre-hospital guys are also aware of those changes. We are working on the stroke protocol together. They're actively involved. We're trying to implement the Angels Initiative. Whether we are changing any numbers, when we're changing how the doctors operate, we have that cordial relationship, and that happens across the board, even in the other facilities that I know the emergency physicians work in. They have that relationship because we understand that it's a continuity of care, and we try and also instill that within the doctors. I know I'm not sure about you guys' experience when it comes to the interactions with the doctors and handovers. I would really like to hear how you feel we can better improve those relationships.
Why
Thulani, you
didn't
can
you
go
put up
first.
a trip? Why? Why didn't you intubate?
I think for me, when it comes to I remember the frustration I used to have when I used to go to Baragwana Hospital in Johannesburg. And I was working in the ICU ambulance. I'd arrive with the patient from one of the small clinics that we've worked hard to stabilize, right? We've intubated the patient, we've put them on the ventilator, and now there is no direct admission to the ward, so they're going to ED. You arrive in ED, you find doctors. And the doctors, they just look at you. What are you here for? You didn't tell us you're coming. There's no oxygen. We don't have ventilator for that patient. Like I'm thinking, but I've worked hard on this person, and then I find that resistance. And then they say, why did you intubate the patient? There's no ICU beds. Now, I don't know what to do now, especially because it's an organized transfer. I think at that time, the issue was communication between the control center and the hospital. And that leaves us in the middle. You do your bits, and then you end up frustrated. It was just frustrating. And then now you're trying to hand over to a person that doesn't want to really take the patient. I understand though that if there is no ventilator, you don't have capacity in terms of human capacity, you don't have a bed, you're stuck too as the hospital on the other side. But I wish there was a way that you could communicate that. I don't know. I think there's the culture with the doctors that is just, how do I say this? Where they are condescending sometimes, I understand that that's the final destination for healing doctors in hospitals. But I do think that we work together, and I didn't put myself in this position, and I've done my bit. So let's just work together, and understand that I can't just turn around and send the patient back to the clinic or take the patient to the ambulance station when I come from. I can't do that. This is where I need to be. So welcome me, please. Yeah, that's how I normally feel. It's frustrating.
So for me, I think I've most of my career I've worked for private ambulance services, and to compare the two, I've worked for the two biggest private services in South Africa. Is that whenever we go to private hospital to hand over those patients in the emergency department, the staff was more receptive, was more welcoming for us to bring those patients, and also the fact that some of the private hospitals that are ambulance services that I worked with were aligned with the private hospitals. So we sort of like form one part of a team where they're used to you, they know what are your capabilities. They also, some of the nurses did some trauma training with us on the road. I remember at Netcare, they had that program where Netcare 911, they had nurses that come and work with us so that they get to understand. And when they go back to the ED, now they don't ask us, why didn't you put up a trip? They get to understand all the challenges that we have in the pre-hospital setting. Whereas in the government, whenever you take a patient there, they never trained with us. They never did their trauma training. I've never had to work with them on the road to do their training with us. And we still had those challenges where even if we always try and humble ourselves, because first of all, the patient humble us. And then, you're going to hospital, you want to try and avoid that conflict. And you go there humble, like, okay, we've got this patient.
It's true.
Please take it. Please assist us with that patient. But I hope that, because you asked a very valid question, that how do we fix those relationships? I hope that we do have, I don't know, I think we need to have those interprofessional collaborations, not just for us that have already qualified, but also from the training itself while we're still at the universities, to say nurses need to be aware of what paramedics do and vice versa. Even the doctors need to know what we are capable of, what we do, and all the challenges, that can break the stereotypes, the stigmas of what we do, and also strengthen the relationships that we have. Because in essence, the fact that if you take Malusi's patient right now, you've got a patient that is on a mechanical ventilation, that is connected to oxygen. The oxygen might run out. He's stressed that he's transferred this patient from one place to another, and he's waiting for a bed to be available. So all of those challenges are not nice. They add additional pressure to you as an individual. So I think part of it needs to be that interprofessional education about what we do. Because we also come there, might have an idea what doctors do, might have an idea what nurses do, what they go through, but we need to have that culture change shock amongst ourselves. Yeah. I don't know what you think, Elias, or even you, doctor, because you're also part of the team here.
No,
In the spotlight.
no, it's 100%. The thing is that I've really encountered many of those situations. Sometimes I've been on the receiving end, and sometimes I've been on the giving end, and mostly it's also been from a place of ignorance, because in all honesty, I always used to think that, okay, one, paramedics are just interfacility transfers, and secondly, you're just there to pick up the patient and bring them to hospital, and you're supposed to provide some form of care. And if it's a seizing patient, again, I'll be like, you people, you didn't even put drip. Yeah, like we tried. I mean, okay, no, it's fine. You go there, you get the drip, and then you are there also trying, and you are just seeing the paramedic there in the corner, like, yeah. Yeah. Did I not say we tried? We try. You can do it, most. Try it. Also said, why is the ventilator so messed up? And then you are there. Also, you are like, guys, even me, I'm like, why is this patient not becoming better? And then in the side corner, you're like, guys, just pack up, go, let me try something. But then it really humbles you. And it brings you to that point of just that collaboration between the team, where I'm like, okay, guys, tell me exactly what you guys have done so far. And really, I never really picture anything as much of an emergency for us to be rushing around without having a background. So while we're putting the patient on, someone is starting chest compressions or someone is trying to put up a drip, what have you guys done so far? Have you tried this and this? Okay, no problem. This is what we're also going to try. And that way we also now, because most of the times when you drop off the patient, you don't get the end story of what exactly happened. So we're like, stay, let's see what else we can do. Maybe you guys also have good suggestions and we move from there. And it's also from a place of humility where sometimes it's you become the bigger person by remaining vulnerable and saying that, guys, even as we struggled, and as being part of the pre-hospital team and dropping off patients in tertiary facilities where the doctors look at us, and at that point you don't identify yourself as a doctor, and you get the receiving end of seeing how aggressive we actually are from the other side. You get to see that, guys, let's just humble ourselves, let's talk this through. All of us are going to be struggling with the patient in the long run. Let us tell you what we have done, and you guys can also advise us on what we could have done better. it's a place of vulnerability, it's a place of humility, it's a place of learning, but in the end it's for the benefit of the patient. And when you walk away, I think there was one paramedic who told me that, look, I have the encounter, I hand over the patient and I leave it at that, and I don't think about that encounter anymore, and I leave. I learn what I need to learn from whatever it is the doctor said. Anything that was negative I throw away and I continue with my life, and it helps the next patient from whatever they said. But other than that, we continue with life.
There's something I wanted to add there, Elias. From Thulani's point.
Yeah.
So if you've worked for the private sector, the difference is that the private sector also appreciate that the patient is going to be part of the clientele, and they're going to increase the fiscus of the business. And they're trained to understand that. I remember, I think there used to be hospitals that will give us snacks when we bring patients there. Now, if you bring a patient, if you bring a patient that, I remember there was once a patient, it was a Saturday, I remember, patient was driving a BMW, there was a car accident, I think it was 2012 in Port Elizabeth, had a head injury, and I intubated the patient. He was drunk. So I ended up taking him to hospital, and I came back, I think possibly 2 weeks later. For some reason, I wanted to know what was happening with the patient. And then they told me that he had complications, but he was still alive. He was still in ICU. He was going to go for rehab after that. And then I saw the bill that he had. 2 weeks, it was about $500,000 rands. And that's a lot of money. Now, if you compare that to the government has a bigger population, and the clinicians, they are overwhelmed with work, and like they literally don't have a space to put the patient, and the human capacity and the equipment capacity is not there. You bring the patient there, they're frustrated. So I understand from their side. I think we also see it with nurses too. Funny enough, it still happens even here. I normally laugh at the nurses here that I've built relationships with. When I walk in with the patient, you can literally see their faces drop. And because they're not excited that you're there, you're bringing more work. But if I come with an empty stretcher, they open the door for you, they say, "Who are you looking for?" And they give the patient, because you're taking less. So it's about work too. I do appreciate that too, but I do wish that it doesn't end up being a toxic work environment for everyone, because we're trying to do our jobs, everyone. And my job is to bring patients to you, and you continue from there. And that's it. And I can't there's nothing else I can do after that. I can leave them. Sometimes I even say, do you want me to take them to the station until they, because I don't know what to do. Like, if you are resistant, what am I going to do? Yeah.
Go ahead, Thulani.
I wanted to say something that you mentioned. There's two things. Is that there's Prof. Andrew McKink. He did his study on the process of handover, this PhD on the process of handover. And I never thought that handover is quite important until I had that discussion with him and I read his thesis. And one of the things, there's a lot of stuff that he said there on his PhD, but when it comes to handover, is that it ensures that the continuity of care from one practitioner to another is smooth, and also the information that we give, you guys can use that in the hospital, can use it to better care for the treatment. So I just wanted to add what you said, is that if they don't even listen to the handover that we give in the hospital, then it's going to affect the continuity of care, because there's things that we might have done or might have the information that we have that you guys might not be privy to, and might be necessary when you treat the patient. But I even forgot my second thought, but you can go ahead.
I just wanted to give some perspective. For the particularly the emergency department, when you bring us a patient, and I'm going to revert back to my state days, is that we are not frustrated with you bringing the patient. We're frustrated with the fact that we won't be able to give that patient the care that they deserve. In that, when we think about a patient who comes in who's intubated and we have to put them into one of our resus spaces, remember that that's supposed to be a temporary space for us to be able to stabilize, resuscitate and stabilize a patient and send them to definitive care, whether it's a high care setting or whether it's an ICU. And that's not the ideal place for you to keep a patient who needs hourly blood gases to change their ventilator setting if they're asthmatic. It's not the place if you're a DKA patient for us to be changing your fluids, changing your electrolytes, because again, we don't have that capacity in terms of resources, in terms of human resources, infrastructure, and then the outcomes that we have for those long stayers isn't great. So there's that interface where now even us, we have to take another hour, hour and a half discussing with the tertiary facility, telling them that, guys, listen, even me, I don't know how to continue managing this patient because I have 30, 40 other patients who are waiting for me outside. And then I see, Malusi is coming again. He just brought some, now he's coming again. It's not.
Where are you getting these people?
Exactly. I'm like, no, guys. And then now you bring, and then I still have 4 chest drains that I need to put in. And then there's still an intern that I need to teach. I need to teach you how to put in this chest drain so that you continue with that. And then the nurse is here like, doctor, you still have to go. And I'm saying, okay, I'm one human being. So the frustration isn't from you bringing the patient. It's just that I won't be able to provide the care that I want to, because every time I pass by the green area, the people are there like, look at this one. Is she even doing something? I'm there on the phone trying to. It says the doctors are always just on their
TikTok.
phone. I'm frustrated. I'm trying. So then it just ends. It's like a vicious cycle. So it's not that we don't appreciate what you guys do, but it's just that on the other hand, we also have all of this complexity that we're dealing with. And then in the morning, the consultant is like, you people, why is the hospital so full? And I'm saying, okay. Okay. So yeah, it's just it's frustration from both sides. It's from your side, our side. It's just like, where do we find each other to meet each other halfway? And as Thulani said, the handover process is so important. And I don't think we do that adequately, because there's so many details that you guys find on the scene or on the other side that doesn't get translated, which actually makes a very big difference in this patient's management. Because sometimes it says, okay, it's a seizing patient, but you also heard that, oh, they had a hemi at home, or they've had previous MI, or they've had a previous TBI. I don't get that. So I start managing this patient from the start, and vital information gets missed that could actually change the trajectory of this patient. So the handover, that we really do need to work on a lot more. But what I find is that your handover reports, I don't know how you guys do it in the global north, but from our side, we really like those pages that you guys fill in. I'm able to see what the vitals are, and I think the pre-hospital guys do that really well, and it's important information.
Wow.
One of the things, sorry, Elias, just one more comment. One of the things that I've recently discovered that doctors do, which makes me uncomfortable, but it's okay, is that when
Why are
you
you
hand
uncomfortable?
over, they take out, well, first of all, they take out their iPhones and then they record me of what I'm saying.
Oh.
But
Do you sign a consent form?
no,
Are you sure it's an iPhone? Maybe it's an Android user.
no.
Yeah, proceed.
But anyway, I think because in that event, it's very stressful. So they get to listen to the notes of what we said in the pre-hospital setting. And then that helps obviously with the continuity of care. I think that approach going forward maybe can be employed in other places. But also I think the way things are being done currently is that you get to hospital, you move the patient to the other scene, to the other bed, and then before stuff gets done, they're like, hang on, Let's wait. Let's listen to the handover, and then everybody listens attentively to what you're saying, because there's a respiratory, there's people that are assisting around, and then there's the physicians that are taking care of the patient. And then once that process is done, then the treatment gets done. But yeah, that's Elias. Sorry, man.
Yeah,
Quick
no,
one,
I'm just,
but
yeah.
when when you speak about that, is you're speaking about it in the critical patients, but then in the state hospital, you usually end up handing over to whether it's a nurse or another doctor, but it's not the doctor that sees the patient. And then you keep bringing like 20, 30 other patients who are sitting there, and it's never the doctor who receives the handover that sees that patient. And there's no record for us to be able to see, okay, what actually happened to this patient. It's just a confused or aggressive or combative patient that you found somewhere. We sedated the patient, they're there, but they only get seen probably 6 or 7 hours later because we have a whole other resuscitations that we have to attend to. So again, that handover process needs to be more formalized, whether it's a piece of paper that is left by the patient, or because again, it's not always the treating clinician who gets the handover for that patient.
I think you've highlighted that those challenges are there. We need to appreciate them, whether especially in the states, in the government
Facilities.
hospitals or state facilities. Thank you for that, Malusi. We need to appreciate that they're existing, and also if you look at some of the private ambulance services in terms of their paperwork, it's more digital than paper based. And we need to find that common ground whereby to say, okay, these are the challenges that the state is facing. I know when I worked at Netcare, we used to have obviously digital. I'm sorry that I'm talking about Netcare 911, but it's where I come from, and I think it's good to share that context that although we had digital or electronic EPCRs, we also have paper-based PCR where you'd write it down and leave it for the hospital. I also know for ER24s that there is a copy that you leave for the hospital. And also, even at government ambulance services, they do have a copy that they will be able to leave, which is important, as you've highlighted. Yeah.
Mm.
It also something to think about, that we have a system where we actually use the electronic copies, and they are automatically transferred to the ED desk. And whenever you hand over, that can be seen by everyone that has touched the patient, and it gives context. And if you think about it, you're saving trees, and you're
That's
saving
a Aussie
trees.
speaking right there.
Apart from saving trees, it's just continuity of care that is just documented. And I think it's easier than printing paper, just sending an email or sending that link that links to everyone. I think it's very progressive. And if you think about community paramedicine too, or community care of any sort, those people can also tap into that and see what has happened. I think just continuity of care continuously. Yeah.
I think I think this is just a small comment, Elias. We're solving the world's problems a little bit, but yeah, continue, Elias.
One comment at a time. Saving trees too. Can you imagine?
Yeah.
I think Maggie, I just want to take you back to the numbers that you gave me here of the EMs in Namibia. There is 5. Now, when you are speaking of definitive care, I don't think that's adequate for a country that has 14 regions. It's absolutely not enough. And I know government is a different beast. Like the workload, as you just mentioned it here, it's different. And the systems in place do not support the clinicians to perform to their best, because you have 5 patients waiting. You might only remember one history or 2, and then the others you kind of have to go back and you work with what you have. What can we do, or what can be done in Namibia to try and increase the number of EM physicians, at least to have 1 per region?
So
I-
we No, it's fine, Thulani. You want to say something?
No, I'm off ramping here. Like the yo, I felt it. Yo, you know, sometimes your the way you talk, I'm like, is this person South African? Because yeah. But anyway, continue.
Okay. Okay. So we have five. It's not a lot, but it's more than what some countries even have. And the fact that emergency medicine is even recognized as a specialty is such a big achievement. And again, I am really standing on the shoulders of giants, because the work that is being done in the background by these emergency physicians is phenomenal. I am literally just stepping in and being like, okay, guys, where do you need the hands? And we have a few more that are coming. We have, I think, 3 or 4 more that are in the pipeline. But to increase the number is for us. I don't think it's more a matter of getting more emergency physicians that will change the trajectory of how emergency care is delivered, but it's genuinely a systems thing where you don't need an emergency physician in a hospital to be able to provide really good care. The WHO has training courses, for example, the basic emergency care courses that can be rolled out into health facilities that will really help you manage those emergencies and recognize them and manage them appropriately. They have minimum standards for what a resus trolley or what an emergency department needs. The oversight of an emergency physician within a hospital is just making sure or just advocating for those systems. But this can be done by a non-emergency physician or with the support of an emergency physician elsewhere. And that is also the model that I'm trying to see if it's something that can help, and what I'll be working on in the next couple of months to years. So getting emergency physicians is great, and I would love us to have more so that we're able to speak the same language. But I don't necessarily think that it's the answer to our problem, because again, when you think about emergency medicine and where it comes from, and you look at the global north, emergency physicians are actually on the floor. They're seeing patients, they're treating. And I'm sure when you guys take patients to your facilities, you have like a team of specialists all over the patient. They're the ones, you have an anesthetist, you have a cardiothoracic. That model will not work in our settings because we don't have that. Our teams are usually very bottom heavy in that we have medical officers, we have interns, and it's not the specialist who does any of those interventions. So the specialist is just to assist, to facilitate the training and upskilling and strengthening the emergency care system, but not necessarily the one who will be doing all of that. So if we can get that right, then we can change the model of how emergency medicine is delivered in the low middle income setting. So yeah, hope that answers your question.
Sorry, Elias, can I add something there? I've been thinking, just listen to this number 5 that keeps on popping. Lesson that I think I've learned from the podcast that we do is from, I'll make an example, Dr. Rabin Naidu and then Lloyd Christopher that we recently spoke to. One thing that is common between them is that they both qualified within the first 3 years of a development of a specific program of paramedicine in the late 80s. And if you look at them at the moment where they are placed, they are in a leadership positions where that actually drive the industry. For example, Dr. Rabin Naidu is a director of emergency medical care and disaster medicine in South Africa, and Dr. Lloyd is HOD at University of Cape Peninsula. Now, they have strategically placed themselves because there was a gap. They were one of the few people, and they have worked hard in developing systems that they're learning, and they have tried to understand where they are and use the resources that they have to design a system that is going to serve generations. We do see some issues as we talk here in the solving issues in the podcast and chat. And that is what we do, but they are supposed to then create those solutions for that. But that's also our task, that as much as they have done something that is great, designing the emergency medical care diplomas, degrees, and all that, but your job there in Namibia is big. You're one of the first, and it's very key. One thing that I'm in a regional hospital. Here they have a CT scan and an X-ray. They do have an anesthetist and an emergency physician. They don't have any other specialties. Some others do come in, pop in now and then. But what they do is there's the main hospital in the city where there are doctors that are always ready to be consulted. In ED, there's a video that can zoom in to the patient and look at the patient. And there's a big screen where you can talk. So you bring the patient in, you consult with them, and they can see what you're doing and how you're treating the patient. They can actually count the breaths of the patient and look at the chest rising and falling of the chest, and they can guide those physicians through the steps of the skills that they're doing. So it's something that we can consider too in an African setting, if you think about it, because you don't need to have everyone in 14 regions. You can have some other people in the center somewhere there, and then they can assist in management of patients, and that can be a big improvement. I think it's financial resource in having the videos and the internet that functions. Technology is our solution. I think in Africa, we do need to invest a lot in that. Yeah.
Thank you for sharing that, Malusi. I hope, Dr. Maggie, I hope that can be something that can be in some way in, I don't know, somewhere in Enana, and while you're in Windhoek, you can always consult to them and you can give them advice. I think that would absolutely be amazing. I know that you did speak about sort of like advocating for different systems. I just want to understand, what's the system that you have if someone is in, let's say, for instance, tapping where there's no emergency physician and they want your assistance? How do you currently speak to them, or how do you support them in that instance?
Okay. So let me put it this way. My role currently is just providing emergency care for the hospital that I work for and building the system there. But I'm very fortunate enough that my hospital management is extremely supportive in the role that I play in the bigger scope of emergency care. And if I'm able to provide emergency care in other settings, whether it's in the state facility, and I have really good relationships both with the people in the state hospital, the doctors, as well as the paramedics, and across the board. So if any paramedic, but this is usually just in a more personal capacity, they are struggling with something, they're able to call me and I'm able to assist, whether it's in managing the patient, drugs, or ventilator setting. And I do have an agreement with the hospital or with the state, because remember, private is different. If I want to assist in anything in the state hospital, I do need permission from the Ministry of Health to do that, and I do have that, but it's mostly just to be able to provide it in a supportive capacity. So currently it's just in a supportive capacity, and I can't take up that role in a bigger capacity because then everyone will be calling me, but it's just in the really difficult cases that they're able to call me. And this is not only from the pre-hospital setting, but it is also in the hospital setting. And it's just an intercollegial, I don't know, there's a word for it, where you're a friend or you're a doctor and you're really struggling with something. As a specialist, I do have that responsibility to help you and see if there's anything else in my capacity that I can help with.
Yeah, Thulani, you can go for it.
Sorry, Elias. I wanted to ask because we've been speaking about emergency physician, and that thing struck me same as Malusi and Elias when you said that there's like 5 physicians in Namibia. That's like Okay.
There were 3 million population. It's not that big.
Yeah.
Thank you. That's what I was about to say.
Three.
Yeah.
You mustn't think, yes, it's a 3 million population.
Wow. Is that according to the World Health Organization standards? I don't
Yeah.
know. But what I wanted to ask you is, let's give context to someone, because people think that a doctor, a medical practitioner, is an emergency physician. What is an emergency English? Sorry, my data can't right now. But
It's
what
nearly
is
You
peak
need
hour.
sleep. You need sleep.
someone who's an aspiring who wants to be a doctor, hopefully not a TikToker or YouTuber? A YouTuber that is watching this podcast can get an inspiration. If you had to summarize in essence, what is an emergency physician? What would you say?
That's a very difficult question. And it's a question that I've been battling with for the last couple of months into a year. Because, look, when I went to study emergency medicine, it was that picture of adrenaline, that thing that you see in. Am I muted?
No, it's just the mic.
Every,
You can come back.
okay. Okay. It looks like everyone is frozen, but okay. So the reason why I went into emergency medicine was I had this picture of adrenaline, like light, and all of these Grey's Anatomy videos that you see. Or TV series that I don't watch anymore for that particular reason, because guys, calm down. That's not really what happens in real life. It's not. Um, and me coming to South Africa and doing the program here, it's like you get to rotate through so many emergency departments. You go into specialty units, you go into ICU, you do anesthesia. So every 3 months, you are in a new environment. And the environments are that intense. You will see really intense trauma. A patient shot 16 times and they're still alive. We're still fighting for this person. And they still get to walk out of the hospital. You sometimes come on shift and you have like 7, 8 patients that all need chest drains. I think my most extreme was I had 4 patients who all had stabbed chests, all coming in next to each other and having to like keep them alive, and then the theater, take next one, take next one. And that's really the emergency medicine that I went into. But then, as soon as I graduated and went back home and got to speak to not only the emergency physicians there, but emergency physicians across Africa, you get to realize that's not really the emergency medicine that we get to practice. And this is not only for emergency medicine, but it's for any speciality, that when you get back home, you actually need to develop that system for you to be able to practice your speciality. So for the first couple of months, even into years, you have to first get the infrastructure, get the equipment, upskill the doctors, upskill the nurses before you actually even get to practice that emergency medicine in the first place. So you continue with what you have until you get to the place of actually doing that. So that's why when I speak about emergency physicians and emergency medicine, I'm talking about systems development. That's because that's actually what we get to do in the first couple of years of our lives. This is across the African continent, where for some people, they actually have to get the speciality recognized in the first place, and having those discussions on what exactly an emergency physician does before we actually get into, oh, we're doing resuscitations all the time. So even for me currently, the resuscitations and emergency work and stabilizing patients forms a small part of what I actually do. The rest is protocol development, and you don't develop a protocol by copy pasting something that you see on the internet. You actually have to see your patient demographics, the resources that you have, and also will your team be able to perform this protocol, because maybe you don't even have these drugs. If a patient comes in with organophosphate poisoning, it's not like you have millions of atropine that you can use. You have to dilute it to a concentration that will still allow for you to have enough resources in the hospital. So that's what emergency medicine is currently for the African setting. We need to get emergency medicine into universities, do undergrad teaching, do do postgraduate teaching to actually understand this as well, and then also start to do our own research, because most of the research that is coming is not our own research, and even when we do our own research, it's not being published. So yeah, that's emergency medicine in a nutshell for the low middle income country. But if I speak to my other emergency physicians from other from the global
Countries?
north, I'll refer
I think
to
Oh, sorry.
yeah.
Yeah, continue. No, continue.
So, from the global north, they actually get to practice that emergency medicine where they are on the floor, they are doing shifts, they are resuscitating, they're doing the teaching, because those are already established programs.
Um, so just one comment, and I think
Oh,
you the second emergency physician that we interviewed. We had Dr. Ben Wachira from
Kenya.
Kenya, and also he did some of his training in South Africa. I think Stellenbosch as well. I'm not sure if there's something about Stellenbosch and Cape Town, but but just to be highlight what he has said. Also, it seems like the two of you are singing the same song. It's just people from different countries that. Emergency physicians should be country specialized because healthcare systems, resources, and the population needs vary widely from the different or from between countries, even if emergency medicine principles are universal. But both of you have highlighted that there is a need for that local context. We spoke about resources, the staff training, the disease, the injury patterns are different from countries to country, and the cultural and social context. You can't take something that is in the UK and try and bring it to an African country. Also, what plays important, the political, the policy and legal environments have an important role in that part. So, in short, is that a country specialized emergency physician can make a safe, efficient, and culturally sensitive decisions that fit within the local system that maximizes patient outcomes. I think that's how I understood it from listening to
A lot has
Dr.
been
Ben
shared,
Wachira
and I think.
as well.
Uh,
Yeah, Elias?
Okay, sorry. I think it's just the internet connection that's messing up a little bit. But yeah, a lot has been said, and I'm sure there's still a few more questions that we have in the background. Since you're just approaching at an hour, Dr. Maggie, if you can just explain to me, there's few titles in your name. There's MBChB, there's MMed as well, and there's FCEM. Yeah, someone might see those titles on LinkedIn. Can you just break down what each means, right? Because some might understand what MB is. And what are the rest of the titles? What's going on there? Who are you exactly when you have so many of those?
so the MBChB is my bachelor's in medicine and surgery. That's the one that I got initially. That's the undergrad training to make you become a doctor. The MMed is now my master's in medicine, which is the dissertation that you have to complete in emergency medicine. That is now with the University of Stellenbosch, and then the fellowship in emergency medicine. That's with the College of Medicine, South Africa. And that is now to say that you are an emergency physician. Now that's the exam that you write to qualify as an emergency physician. So that's just the breakdown of the titles or the
Thank you very much.
qualifications. Yeah.
Yeah, thank you very much. Because we do see them on LinkedIn a lot, and there's people with ones running from one end to the next. So it's good to have insight as to what they mean and what they stand for. Thank you so much. I know there is so many more questions that are to come. We are hopefully going to have a second segment where we can discuss the rest of the questions that we have. But thank you very much, Dr. Akuaake. We say Dr. Maggie or Dr. Akuaake. We really appreciate your time. And to our listeners, please do subscribe, do follow us. Let us know if there's any particular guest that you'd like us to have or any particular topic that you'd like us to discuss. We will appreciate it. And yeah, we love your t-shirt, by the way, Ukolele. We'll be chatting about Ukolele in the second segment. So stay tuned. Thank you. Yeah, thank you, and take care for now.
Thanks.